And we are live. Here we are. Good morning or good afternoon if you're in Europe, or good evening in the east part of the world. We are here for a new appointment of our Saturday morning live talk with the Journal of Cardiac Surgery. This platform that we invented to interview some of the authors that send a publication to Journal of Cardiac Surgery, with the idea of spending an hour in a very informal and friendly environment to chat and to learn and to educate ourselves about heart surgery and different topics of heart surgery. This initiative is sponsored by Journal of Cardiac Surgery, and it's under the leadership of Thomas Salerno, who is putting a lot of efforts to try to bring a journal with extremely high quality content and publishing it in advance respect to all of the other journals each month. So please keep submitting, reading Journal of Cardiac Surgery and submitting your contribution to the journal, and there is highly chance that you can be chosen for your next live talk with us. And I leave the floor to Irbats Ahmed from Yale University in the I6 program to introduce who today is joining us and start then a conversation. Irbats.
Thanks, Gianluca. Hello, everyone. It's my pleasure again to join this live talk. We'll begin by introducing everyone who's here with us today. We'll begin by introducing Dr. El Khoury. He is from University Catholique de Saint-Louvain from Belgium. And we also have Dr. Jama Jahaniar. He is also from the same University of Catholic Saint-Louvain in Belgium. Our third panelist, he is well known as well. He is Dr. Ismail El-Hamamsi. He is from Mount Sinai, New York. Thank you all for joining us. And finally, we have Dr. Gianluca Torregrossa from Lacanau Heart Institute. He is also with us today. We'll be talking about the paper by Dr. Jahaniar and his team from University of Belgium, where they describe their very interesting technique on aortic annulus elevation for aortic valve and root replacement. Without any further delay, I would pass this along to Dr. Jahaniar to give us an introduction of the paper and tell us what their group did.
Yeah, thank you very much, Irbas. Thanks for the kind introduction. I wanted to take the opportunity and first thank the Journal of Cardiac Surgery, Dr. Salerno, Dr. Torregrossa for featuring our manuscript today, and for giving us the opportunity to present on this platform. And with that said, can I have the first slide, please?
Yeah.
And can we enlarge it, or?
This is unfortunately, this is the
okay,
best.
This should work. It's fine. So in this manuscript, we're describing a technique where we adjusted the aortic annulus to the substrate that we had for aortic root replacement. In this case, we had, I believe it was a 17-year-old boy who had a severe aortic stenosis and had a unicuspid valve. And at our center, we like to repair valves, and our goal is always to preserve the valve. But as you can see here on the left, the valve was entirely calcified, and this valve can't be saved. So we ended up resecting the valve. And as you can see here on the right, the valve was resected. The patient also had severe calcification onto the aortomitral curtain, all the way down to the anterior leaflet of the mitral valve. And luckily, in this case, the calcifications were not transmural, so we could carefully tease them off. The way you do it is just you take your Metzner scissors and slowly try to elevate it. And then the next slide, please. So when we did that, you can now see, the areas where we resected the calcium. It all looks good. Sometimes, when you have transmural calcification, you're obliged to resect it and then reconstruct the aortomitral curtain part of the and the mitral leaflet, especially in patients that have a mitral valve disease. But he's young; he didn't have any mitral valve problems. But in this image, you can see that there was some aneurysmic changes of the left coronary sinus. And next slide, please. And what happened is that the annulus in this patient was displaced into the left ventricular outflow tract, down into the left ventricular outflow tract. And in this patient, so since we couldn't repair the valve, our next treatment strategy is to do a Ross procedure. And in this patient, we did a Ross procedure with graft reinforcement. In this video, I want to briefly show how we do that. So after we harvest the pulmonary autograft, we place it into a cardio-root graft. And the cardio-root graft is very similar to the Valsalva graft. It's a little bit easier to handle, and we prefer this for a Ross procedure. We used to do it with the Valsalva graft, but we use this primarily. And here you see one of the commissures is secured to the neo STJ. That was the first commissure, and here we're doing the second commissure and then the third commissure. So that's the first step. And the lower skirt below the Valsalva portion is also entirely removed. We then flip it over to the proximal part, triangulate it at each commissure, and then sew the proximal end to the proximal end of the Valsalva portion. This is how we make our graft. And then here it's sewn with an simple suture, with a 4-prolene suture. The autograft is sewn to the Valsalva or to the cardio-root graft. So now in this image, you can see the pulmonary autograft reinforced in the cardio-root graft at this stage. So here is the first time where we check the graft, make sure that the valve looks okay. So we use some cold saline and look at it before we seed it into onto the aortic annulus. And if we have to, at this stage, we can easily readjust the sutures at the STJ. But this was not necessary in this case. So now, when you look at the pulmonary autograft, the graft reinforced pulmonary autograft, you see that the line that's created proximally is a horizontal plane. So we now have to sew a horizontal plane to the aortic annulus. And the way we do it is we sew it to the basal ring, or to the virtual basal ring. So it's one plane. We don't scallop it. But in this case, it was difficult because the aortic annulus was displaced into the LVOT. So next video, please. So the way we fixed that is we elevated the annulus. So we used the remnant of the cardio-root graft and sewed it to the left coronary sinus. We started in the middle of the left coronary sinus with a 4-prolene suture and went to each commissure, to the right and then to the posterior commissure. So we already had this graft, and we used it in this case. So we're just going to continue. There you go. So no, actually, I'm sorry. Can you go back to the video? So can you go back and just forward it a little bit? Okay, go ahead. That should be good there. So actually, a little bit, please, Gianluca. So we'll just wait. It's very short, the video. So now, once it's seated, we cut it to align with the normal annulus. So the graft is trimmed in order to align the height of the graft with the height of the normal annulus. And here it's fixed to the commissures. One thing I forgot to mention is, this displacement of the aortic annulus in left coronary sinus is actually more common in the non-coronary sinus. So it's unusual to see it here, but this is also an unusual case with a unicuspid valve, which in itself is very it's very rare. So here we secure the graft to both commissures. Here the right left. I'm sorry, non-right. And here we're demonstrating how the pulmonary autograft is then sewn to the neo-annulus. And we don't. I'm not going to show all of it. We're just going to show the beginning. This technique is described in detail in one of last year's editions of the Annals of Cardiothoracic Surgery. So as you can see here now, the annulus is elevated in the left coronary sinus and matches the height of the annulus at the remaining aortic annulus. And with that, we now have a horizontal plane of the pulmonary autograft that can be sewn to a horizontal plane of the aortic annulus. So we have a perfect match. And with that, I conclude my presentation, and now we can see what everybody has to say.
Thank you so much. Very nice presentation, excellent pictures, fantastic video, as I told you even before the live. Really impressive, the quality not only of the surgery, the quality of the video and the presentation. When we read this article, we were very interested for uniqueness and this concept of annular flattening the aortic annulus. Ismail, I would like you to involve Professor El Khoury in. Have you ever seen, Ismail, a situation like this? Do you think this is a potential good technique? Have you ever used a technique similar to this one? What do you think when you read the paper? What is your take-home message?
Well, what I think when I read the paper is, like anything Jibrin does, there's always a lot of art and a lot of thinking. So this is a very nice technique to palliate an annulus that is not, symmetrical, where you have one part of it that is deep into the LVOT, and that sometimes that can be an issue if you're doing a case like this for a Ross. It can be an issue sometimes, or this approach of putting a Dacron ring to elevate the annulus can be used in destructed annuli if you want to put a prosthetic valve. So there are different instances where this technique can be useful. This is a very unique situation where the idea was to make it in a planar fashion. What I'd like to hear Professor El Khoury tell us about is what is the, I mean, the way I see it is we're creating a solution for a technique that was introduced, which is putting the autograft in the Dacron graft, and therefore the annulus becomes a very stiff horizontal plane. Now, so you're creating a solution for something that you're introducing. Do you think that not putting the autograft in that Dacron graft could be just simply a way of implanting the autograft without having to go through these subterfuges, through these inventive solutions?
Yeah, I mean, the idea behind this, if you the sinus was so deep that if you want to implant the autograft without the prosthesis, first you have to scallop it because it is really very deep. You have to scallop to make like an crescent form the proximal plane. But you will have a problem because in this situation, the implantation of the left main will be higher than the sinotubular junction, and it is not really recommended, as you know, to have a long autograft. So we have always to try to find, let's say, equilibrium, let's say, between the depth of your sinus and the implantation of the coronary ostia. If it is a stantless things, it's stantless, so it is not really rigid. So it means that the LVOT, if it is quite a little bit rigid, may a little bit make a deformation on the autograft and include some kind of distortion and dysfunction of the autograft. So the idea behind this is that first you respect the position, the situation of the coronary ostia. Second, you don't distort the base of the stentless things. Now, if you are using stented one, you may induce some kind of traction of the valve and induce mitral regurgitation or whatever. So, this approach that we should really respect the fitting between the material and the base of implantation, and we can see it at the level of the non-coronary one or of the left. It is very rare to see it on the right side, and this is we learned that it is really very important to respect this fitting between the base of the autograft of the stentless and the annulus itself.
Very good, very interesting, Professor, as always, as Ismail was saying. Ismail, please, I think you want to say something more.
No, well, I mean, I just want to, we can open the discussion to, I think there are many discussion points here. We've discussed several times before the value or the merits of putting the autograft inside the Dacron graft.
Yeah,
and that's a separate conversation. We can maybe address it later in our conversation if we have time. What I will say is one of the beauty of the autograft, the pulmonary autograft, is it's very adaptable because it's a native tissue. As Jibreen was saying, it's not stented. It really adapts to any anatomy. I think the principle behind this is to make sure that the diameter of the aortic annulus matches that of the pulmonary annulus. That's step number one. And in patients with unicuspid valves, oftentimes the annulus is quite enlarged, and it's a little bit larger than the pulmonary annulus. So step one is to really make sure that you have a matching of the sizes, because we know that this is a predictor of recurrence. How do we do that? That's one way of doing it. You just put the autograft inside a stiff Dacron graft, and then if you put a Dacron ring at the bottom, then you've essentially made sure that your autograft will not dilate. You have to hope that the native aortic annulus doesn't dilate over time. The alternative to that is to do an annuloplasty of the aortic annulus. It's an extra aortic ring annuloplasty, and bring it down to a size that matches that of the pulmonary. Sorry, go ahead, Jibreen. Did you want to?
I have one comment about this. I agree that if you put a prosthetic material, that's okay. I know 20 years ago, the beginning of our experience with Ross, we used to put a pericardial band, and we abandoned this technique because the pericardium is not protective. Mm-hmm. It is hemostatic only, but it is not protective against dilation, because we had many redos on autograft, as you know, and every time I had a redo on autograft on Ross, the pericardial band is calcified, but the aortic annulus is dilated. The autograft is dilated. So it means that, yes, the pericardium is not protective against any further dilation. It is okay at the beginning, immediate post-operative course, because it is hemostatic. But it is, and the second that make the redo very difficult, because we have a ring of calcium around the autograft, and take time to take out the calcium and to preserve the valve. I have some patients who I could preserve the autograft, but you have 1 hour time to dissect all this calcium around this autograft.
Oh, I agree with you 100%. I think pericardium should not be used, and it should certainly not be used either as a washer, because it's a very hemostatic suture line, you don't even need it, or as a support, because it doesn't stabilize anything. What I meant is to use a Dacron ring annuloplasty. So as if you're doing a mini reimplantation, but just keep it very short. The other thing is and once you do that, I think you can implant the autograft even in an asymmetrical. Remember, a normal aortic annulus is not a flat plane. It is also a three-dimensional structure. And the autograft, provided it's not put in a stiff Dacron ring will adapt to the shape of the annulus. You know, the non-coronary sinus is always deeper than the two other sinuses in a normal aortic root. When we implant the autograft, it just sits and adapts nicely. What I do is just make sure that very tall commissure between the left and the non and unicuspid valves, I close that with a suture, and I implant more in a almost a planar fashion, making sure that the two raphes essentially work as your reference point in terms of how high you're going to go. In this very instance, the autograft will sit a little bit deeper in the left. As Jibrin said, it might cause a bit of issues with reimplanting the coronaries, but it's so forgiving, the pulmonary autograft, that even if it sits a little bit in the sinotubular junction and it feels low, it won't kink.
I agree that small difference in height, it is not really a problem. The problem is that if we have more than 1 centimeter or even so, and as Jama said, the left one was the aneurysmal, so it means that was really pushed down into the LVOT, and you have maybe the height. I can see it at the video. The height of the elevation was 15 millimeters or even 2 centimeters. So the difference was too big. For why in some patients, when the difference is really very important, we have to do something.
And it's a beautiful solution that you showed. I mean, it's very elegant. The result was perfect.
The second thing, Ismail, I think you will agree also with that sometimes the non-coronary is so deep that I remember when I was very young, I am still young, that the autograft, the posterior part was really anastomosed or fixed on the sinus, on the aortic wall, and so there was no protection for this for this area, and I think that is not a good technique. It's good because we'll have the same plane, but it is not, the posterior is not supported. The non-coronary sinus might be very fragile, and we have some kind of bleeding over there. So in this situation, even if you put your autograft a little bit high into the sinus, you may have some problem. And I prefer put some elevation over there, solid elevation, in order really to have a very horizontal plane, let's say, of implantation.
You know, I go back to when I did my PhD with Professor Yacoub more than 15 years ago. I spent 4 years, and the title of my PhD thesis was "The Living Aortic Valve." So I still have so much, respect for the physiology and the dynamism and trying to not put anything that is rigid or artificial there. So, you know, I hear you. I mean, I think it's that there are instances where we have to, but I think these should be the rare instances. As much as we can preserve that dynamism and the normal aortic.
We are talking now about the autograft, but if you have a let's say classical mental, biological or whatever, you may have the same problem, because you have sometimes the temptation to put your stitch very deep.
Oh, 100%.
And you will bring up, or you will pull on the mitral valve and use our mitral regurgitation. So this concept of trying first to let's say to respect the stentless thing, and second, if you are using a stented one, to respect the mitral.
Yeah.
So that's really those two ideas. We should always keep this in mind. You have in case of calcium, disruption of the aortic annulus, or endocarditis or whatever. Sometimes we have the temptation to go very deep into the arterial leaflet, which is not good.
Yeah, and I think that's the translation of this technique is for stented bentols. I think this is a very useful adjunct, and I think that's something that all aortic root surgeons should have in their back pocket for some instances or some cases where,
I'm not saying that
redos
every day, but
exactly. It's a tool. It's it's an added tool in your toolbox.
Yeah, we have sometimes patients coming to you for aortic surgery, and the mitral is this way. The coaptation is limit. Sometimes you need maybe a small traction on this, and you will have a very let's say severe or at least worsen the mitral regurgitation. So we have to keep this in mind, that the no traction if you are using stented valve, if you don't put your stitch very deep into the LVOT in order not to interfere with the valves. Mitral.
Gemma, 1 second. You are muted.
Okay, sorry. Okay, can you hear me now? Okay.
Very well.
So I just want to add one more thing. So although this particular way of doing the aortic annular elevation is rare, this was in a patient that had a unicuspid valve. So, already abnormal anatomy, and then we use this pulmonary autograft. But this idea of annular elevation, we have been doing, for instance, with Bentile procedures. We don't always sew the composite graft at the level of the valve to the annulus, especially in annuli that are very destructed, like in redos, where you don't really have an annulus anymore. We sew the graft itself to the annulus, and then we always tailor the graft to the anatomy of the aortic annulus. Let's say usually we leave the graft below the. I'm not sure if I'm making it clear. So if we're doing a Bentile, the valve is here.
Handmade the Bentile. When we do ourselves the Bentile.
Yes.
Yeah.
Exactly. The valve is here, but the graft that we are sewing to the annulus is here below. Yeah. So, and the skirt below the valve, we tailor according to the annulus. Exactly. So this technique of annulus elevation is actually quite common in Bentile procedures.
Yeah.
So it's a very useful technique, and it gives you the ability to adapt your Bentile procedure to the annulus that you end up with in your redo surgery or even primary surgery.
Absolutely. I think this is, so the first, very quickly, Ismail, I want to know, what is your recipe when you do a Ross? My experience, I told you already in a dinner in New York, Ross is my deep down secret love of art surgery. And I've done 13 with Paul Stelzer when I was his fellow at Mount Sinai.
13 is another good number. Good.
13, I have to do one more. I come to Brussels and I do one with you, Professor, tomorrow. What is your, and I remember his technique, Teflon down, autograft implanted as a free graft, and then try to leave some of the tissue in the non-coronary to support posteriorly the autograft. What is your technique briefly in your description?
Briefly, Gianluca, in patients with aortic stenosis, I mean, the overall principle is trimming the autograft to leave really no more than 2 millimeters of muscle below the leaflets. That's number one. Number two is I use single interrupted 4-0 Prolene sutures for the proximal suture line. You have to make sure that you have symmetry of the commissures and symmetry of the heights of the commissures. The sutures have to be placed inside the LVOT, so quite deep, so that the autograft sits within the aortic annulus itself, so in a way that the aortic annulus supports the pulmonary autograft valve, because the pulmonary valve does not have an actual annulus. It is just infundibular muscle that becomes dead once you've harvested the autograft. So if you just quickly sew your muscle to the annulus, the valve sits in a supraannular position. This will dilate.
Sorry, to be sure. To interrupt you.
No, please.
To be sure that your autograft is inside the aortic annulus. I mean, it is very important what Ismail is saying. So one trick I do in order really to be sure that my autograft is inside the aortic annulus, that I put 3-stage stitcher at the nadir of each sinus and the pull. So by doing this, you expose very well your LVOT. You put your stitches, you put your autograft, you tie, and after that you take out the traction on those 2 stitches, and you will see that your autograft is really inside this, and that's really for sure. I mean, you are sure that your autograft is really very deep inside the LVOT.
Inside.
Yeah.
Do you run it?
I mean, I now for the last 15 years now, I do running stitch 3.
Okay.
Yeah, three running stitch. At the beginning, as you know, I mean, I used to do the single one, but because of our experience with the aortic valve repair, and we are not distorting the autograft, we pay attention to every detail. So for why I teach and I teach my young colleagues to do in three running way,
Right.
yeah, three running stitches.
So
It's
Ismail, you were saying separate stitches, deep
Yeah,
down.
interrupted stitches. You make sure that every stitch really excludes that muscle on the autograft side.
yeah,
So I
yeah.
mean this way you're sure that you're excluding that muscle, and every stitch on the aortic side goes in right at the annulus and comes out deep in the LVOT. That
Yeah.
really pulls it down. So that's the
Yeah.
proximal suture line.
Yeah.
For the sinotubular junction, you trim the autograft about 2 millimeters above the commissures. And anytime there's just a bit of mismatch between the native ascending aorta and the autograft, I'll use a short interposition graft. It doesn't have to be long. It can be just 1 centimeter in length. It will be a 26 or 28 millimeter Dacron graft. I'll anastomose it to the STJ of the autograft, and then to the alveolate and anastomose it to the native ascending aorta. This way, you're not stretching the STJ, and you're making sure that it stays at a predetermined diameter.
In case of aortic valve stenosis, I think.
No, I'm talking for the distal suture line.
I mean the freestanding route.
Oh, wait. Well, we'll get to that. That's where we'll have a good discussion now. This is aortic stenosis. I think we all agree. Aortic regurgitation. This is the next one. And then Gianluca, just to finish, because again, if you break down the aortic annulus as to what can cause recurrence of regurgitation, it's annular dilatation. So we talked about the annulus, how we address it. Could be sinotubular junction dilatation. So that's how you fix it. And then the sinuses can also contribute to that. You don't want a root aneurysm. And so what we do is, as you mentioned earlier, the native non-coronary sinus wall and the left-right commissural tongue, I reimplant above the distal suture line once I'm off bypass and protamine is given and there's no bleeding. And the last point, which is often mentioned but really overlooked by many, is blood pressure control. And that's easier said than done. So we put patients on beta blockers and often something else. They all leave the hospital with a systolic of under 110. But remember, if you don't monitor this in the first weeks after discharge, a lot of these patients actually start running their blood pressures in the 140 and 150. So we end up readjusting medications in 2/3 of the patients at least once or twice in the first 2-3 weeks after discharge. And I think that really allows that autograft to adapt to systemic pressures. Now, I think this we all agree, but I'd be curious to hear what Professor El-Khoury does for patients with a preoperative AI. That's where I think we might differ a bit in technique.
We repair.
Jabreen, how do you do?
So, yeah, just to give
that's a good point.
Just to give a little bit briefing to a lot of people that might be resident, might not be. So as you all know, RAS procedure in aortic regurgitation has been an incredible discussing topic. RAS procedure per se is a very debated topic, but RAS procedure in AI, it's even more, because in the medium or long term, one of the mechanisms or the most important failure of the implanted pulmonary valve in aortic position is the aortic dilatation, and more in patients who present at the time of surgery with an aortic regurgitation, there is a tendency of failure in this sense. So, Professor El-Khoury, tell us, AI patient, 30 years old, comes to you tomorrow, you decide is the valve, you cannot do a Tyrone David, is not a normal valve, there is severe AI, you cannot repair that valve, you decide it's a ROS candidate. What do you do?
Yeah, any patients coming to me, a young patient, as you say, my first choice is the repair, and the second, I have always a pulmonary homograft into the OR. I order this. So now, if the repair is not feasible, we go for ROS. Now, how we support the ROS? Now, the first situation, if the root is normal, the root not dilated. So what we do is, let's say, and the aortic annulus is not so dilated, because it happened that sometimes you have severe aortic regurgitation, but the aortic annulus is still more or less normal. So in this situation, I like to do the inclusion, the cylinder. It is the autograft is into the native root. I respect the native root, so the autograft is supported by the root itself. That's my
You
first
mean
technique.
a subcoronary or
No,
an
that's not
inclusion?
coronary.
Okay.
Cylinder.
Yeah.
Cylinder, and the real cylinder. We have what we call the inclusion technique into the native aortic root, and that's a little bit more appealing. This technique, the risk if you don't have, if you do any mistake that you will may induce prolapse if you change the configuration of the autograft. So I did it many times 15 years ago, and I had some prolapse, but at that time I was not aware about the configuration of the aortic valve, whatever. And because of our experience with aortic valve repair, understanding all those things, now we can do this inclusion technique, and my valve should be perfect, no prolapse, nothing. And this technique is really very durable. If your immediate result is excellent, it will stay forever, nearly. That's the first technique. The second one is, and I like this, is the Dacron. We implant, as you've seen at the video that shot by Jama. We implanted the autograft into Valsalva prosthesis. For sure, we have some critics about that, but the things that because of the situation, I don't like the straight tube. I like this Valsalva one, and so the autograft is more or less free inside of this prosthesis, and the distal part of the autograft is really very let's say protective for the autograft. The proximal part, that's sometimes you may have some problem. You need some kind of annuloplasty even for that, because you usually depends on the height of your autograft, and the sometimes you have to cut. What is really very important is the cerebral junction, but sometimes the autograft is short, so you have to cut a little bit the skirt of the valsalva, so you may have your proximal plane into the in the large portion, let's say, of the valsalva. So in this situation, we should a little bit adapt the aortic annulus to the prosthesis.
Good.
So that's the two techniques we are using in case of aortic regurgitation: cylinder or supported by prosthesis.
Jama, I want
Yeah.
to go back a little bit to your paper, and I love the concept that we briefly touched before, with the idea of not in RAS procedure, but in Bentall procedure. That is something that more surgeons perform in an everyday basis, and it's what Monday morning, no, you can have book in your. I love this concept of being careful about mismatch among your annulus and plane, particularly in the non-coronary sinus. And I do believe that mitral regurgitation after Bentall is an underestimated problem for surgeons who do not perform many aortic root surgery. And as Professor Alcuri was saying, you take deep bite because you're worried about bleeding, and you suddenly put this stuff down, you try to traction up the aortic annulus, and you have mitral regurgitation. So do you pass your stitches? So you have, let's say you choose your prosthetic valve that could be, I don't know, I don't want to do any advertisement. You use one of the valve available in the market, implanting inside the graft. And do you generally run with a 4/0 Prolina the valve? Is that correct?
Yes.
Yeah.
Good.
Yeah.
Now you pass your pledged stitches in the annulus, correct?
You know,
Tell me
I've
your
done
Bentall
it that way. I've done Bentiles by doing it basically like an aortic valve, but ever since process, I don't do that anymore. You know, I would run every Bentile similar to, you know, to the Ross. Like you know, like with the 3 sutures from commissure to commissure, with depending at what height I implant composite graft. If I do it at the level of the valve, I would use a 2-prolin. If I do it at the level of the graft, I would use a 4-prolin and run it.
That's
I mean,
right. Yeah, so you start with a 2-prolin, and do you always implant? Do you always at the left coronary or the right coronary? Do you always implant or pass your running suture through the stent of the graft using 2O through the stent portion of the valve in order to sit down and have your room for the coronary implantation, or has happened to you that you have just implanted the even in the left coronary, just at the level of the graft itself with a forehead?
It really depends on what you have, what you're working with. So if you have a normal annulus, let's say it's a first time, and then you take a bite through the graft, through the stent of the valve, and then through the aortic annulus. If you but sometimes you have a completely an endocarditis, or in difficult redos. Professor Khoury, has this en bloc technique where he basically resects the entire annulus and is left with the aortomitral curtain in the back and the muscular interventricular septum in the front. And and in that case, I wouldn't sew the composite graft at the level of the valve, but would use the skirt. And you go through the skirt, you go through what tissue you have left, and then you seed it, and then you should do a second layer, hemostatic layer. And you grab the tissue that you have to the graft. There are different ways of doing that too. You can fold the graft up and then use that folded piece to sew it to the tissue. So there are different tricks, but I think the most important thing is that you adapt the lower skirt according to the height of the tissue that you have. You can be left with a lot of tissue in the back, a lot of aortomitral curtain, or you can be left with almost none. You're basically at the left atrial dome. Then you have to leave your skirt a little bit longer. And in general, you want to leave the skirt in the back a little bit lower because the left coronary is lower than the right coronary. And you don't want to do it too high. Then, you basically have to implant the left coronary onto the stent. So there are a lot of nuances, and it really depends on what kind of anatomy you have left to work with.
Speaking of infective endocarditis, I'll take a question from that. This is a very complex patient population. They come with annular abscesses, damaged aortomitral curtains, and sometimes need whole commando procedures. I have a couple of questions that are probably tied together. What is you talked about the block technique, en bloc technique that you were describing. Can you please tell us more about that? And also, what is the role of the Ross procedure in this patient population? There's always a risk of relapse and recurrence of endocarditis in these young patients. What are your thoughts on this?
So the first question, the en bloc technique, is basically a technique where you resect the entire root with the valve in total. The only thing you have to do before is to mobilize both coronaries, protect both coronaries, and then you take everything off. You cut down to the aortomitral curtain in the back and to the muscular septum, interventricular septum in the front. We actually described the technique last year in JTCVS technique, if you're interested. And then, I personally wouldn't do a Ross procedure in an endocarditis case. It's a salvage operation, and our graft of choice is the homograft. But I'm going to let Professor Khoury.
I mean, for the homograft, if we like when we have an abscess, or in case of endocarditis, and we have to do the commando technique or whatever, we like to use systematically the homograft, aortic homograft, to reconstruct. Why? Because it is first, maybe it may defend against the recurrence of infection, but mostly because with the aortic homograft we have the anterior leaflet of the mitral valve, and we use this anterior leaflet of the mitral valve attached to the homograft to reconstruct, to elevate what exactly Jabba was describing. By using the pulmonary, the mitral homograft, we elevate the aortic annulus, and we have a really such a good reconstruction of the aortic annulus with the homograft. That's, I mean, we have many patients, many cardiac surgeon or whatever others say, oh, homograft is not useful. You can use a bental, biological, whatever. I agree, maybe for the durability or whatever, but for the easiness of the technique, for the hemostasis, for the absence of any dehiscence, postoperative dehiscence or recurrence of the infection, the use of homograph, at least in our hands, is fantastic. You really reconstruct the aortic annulus, the aortic root, and we have this pulmonary. Always ask to have the mitral, anterior mitral leaflet attached to this. That's really fantastic one. You don't need to do a pericardial patch or whatever and do bental. You can do that. But if you have the homograft and the anterior leaflet of the mitral valve, it is really fantastic and very helpful to have this. That's my first comment. Now, for the use of FROS in this situation, if we have aortic annulus destruction, I mean, it means that your aortic LVOT is not supportive, or not, your autograft is not supported. So the risk of recurrence of dilation of the autograft is really real, and so for why I do ROS only in case of leaflet destruction, but not annular destruction of the aortic valve in young patients. If it is really extra leaflet or extra annular or annular destruction of the aortic annulus, I'm a little bit reluctant to use the autograft because of this absence of support. I don't like to put a dacron. I don't like to put and I don't believe in pericardium to stabilize that. Why I try to use a homograft, and I would say maybe in 10 years I will do ROS in the absence of any infection.
Ismail, tell me your taking on this.
Very similar, very similar observations to what was said. So I adjust to what I see in the patient. If there's root destruction and you're going to have to rebuild, the ROS is not an option on the table. It's a longer operation, and you're going to have to reconstruct the root, and there are many moving parts. So it's better to just get the patient out of this. So in these instances, either I'll use a homograft to use that mitral flange, or sometimes I'll just reconstruct the root with a big patch of pericardium and use a stentless porcine root.
Yeah,
I use it interchangeably. Yeah, it's a variation on the theme. It's really the same operation essentially. I don't think that the risk of recurrence, whether it's a homograft or a stentless root or whatever, is any different.
The only thing is really to avoid to use, in case of acute endocarditis, to use of a stented valve or subcoronary implantation of homograft or stentless, because the risk of paravalvular leak and disruption is really very important. So for why, whenever I have a aortic endocarditis, the solution for me is bental.
Agreed. And importantly as well, I'll add to avoid any pledgets or limit any prosthetic stuff. So anytime I do these operations, I do it like I do a ROS. There's single proline interrupted sutures. There's no artificial material in the LVOT or anywhere close.
Anytime you go for redo infection, and you will see the infection on the pledget.
Yeah, exactly. I mean, pledgets are really
that's really.
But if the root is not terribly destructed, if it's leaflet endocarditis, or if you only have a small abscess in the aortic mitral curtain, then and the patient is young enough, then we'll definitely do a
Yeah,
ROS in that
exactly,
case. And I think it's a
exactly.
very good solution. We published it. So if you look at my experience, I've now done around 600 ROSs. About 30 of those were patients with acute endocarditis,
Yeah,
and their
Wow.
outcomes are no different than the patients who were done electively,
yeah.
but with very careful patient selection. These are
Selection,
not your
exactly,
bad
exactly.
endocarditis. These are very
When I was,
favorable ones.
I mean, years ago, when I was a little bit excited about everything, I did some ROS with the in the ROS associated to Commando's operation,
Yeah.
but I had to re-operate those patients. So it was because of dilation.
Yeah, and I agree with what you
Yeah,
said. If the
for what?
root is destructed, you have no real support.
Yeah, yeah,
It's a longer operation. It's a bigger operation,
yeah.
and
Sure,
these
it's
patients
longer. Yeah.
can bleed. They can do things. So
Totally. The concept of aortic annular elevation comes in my head when I've done a commando procedure, And during commando procedure, I actually found more complicated to find the right plane to reimplant the aortic valve in the right position after you come up with a skirt that is reconstructing the aortomitral curtain. And I'm not talking about commando benta, where you implant a root on top of a commando. But in commando aortic valve replacement, so where you use that patch just to come up and fill a gap of your original opening between the left and non-coronary sinus, it's interesting to see how you effectively come up and elevate that plane, and you need to very careful select exactly at least of a centimeter or more, and you have to carefully select where you are passing your stitches to reimplant your prosthetic aortic valve. So,
Yeah.
Professor Alcuri, give us a little bit of your own taking your message in this setting. So, commando situation, commando bental, or commando aortic valve replacement. How do you calculate the new height, the new site where you implant your aortic position?
I mean, one easy way to do is when you have your left one is respected, the left sinus is respected, the right sinus is respected, and when you put a pericardial patch on the posterior part, take a pen and draw a line, draw a line on this, draw a sinus, and you can. It's very easy. You have really to have the same height everywhere. So by doing this, you will leave sometimes even 2 centimeters below this line to reconstruct the mitral-aortic continuity. That's really very fundamental to reconstruct the mitral-aortic continuity. Don't go with you. Put your stitch at sometimes at the beginning that you have the temptation to go with your stitch quite deep. No, draw a line and follow this line. And this line should be, I mean, like a commissioner, and should be at least 15 to 20 millimeters above
Both.
your suture line.
and
On the
really
other,
the Gianluca, also to add to what Jabrin was saying, keep in mind always I mean, I know that you know this. I'm saying
No. I mean, I'm
the
here to learn too.
the fibrous trigones are really your main reference point. So identifying the trigones that you can even palpate them, they're just. And I always tell the residents, it's like a tennis net. You have the two posts. These are your trigones, and then you have the net in between. That's your aortic mitral curtain. And a normal aortic mitral curtain is around 10 to 15 millimeters up to 10 to 15 millimeters in height. So the lower part will be your mitral and the upper part, but really you have to fix it at the trigones. That's the best way to ensure that this is a strong aortic mitral curtain. And then
your patch should be triangular.
yeah, and make sure that the patch is large enough and not tense. You don't want it to be like a tennis net in that sense.
Yeah, it has to be windy.
Yeah.
Earbuds.
So I think we're almost getting to the end of our time here. I have one final question, probably Dr. Jahani or Dr. Al-Hamamsi. Everyone can offer some guidance on this for residents such as myself and others who are listening to this conversation. When we're thinking of learning the ROS procedure, what advice do you have? How should we approach this in our training? It's a different dimension and its own worlds in a way, what is your advice for all residents listening to this conversation?
Jama.
So for me, I actually have not seen a ROS procedure during training. And when I was faculty, in the US, I did, my focus was more on transplant, and I did all bread and butter cardiac surgery. ROS was not part of it. That's one of the main reasons I joined the group in Brussels. I learned ROS procedures 2 years ago. Before that, our pediatric cardiac surgeons, would do ROS procedures, but as a resident, I actually never got an opportunity to scrub. There was, with Pedro Del Nido at Boston Children's, and so I don't think there is, if you don't have the exposure, in training, and I think ROS procedure is a overall a difficult operation, and you can do a perfect operation and still have aortic regurgitation. And and the reason may be because the aortic annulus was displaced in the left in the LVOT, like in our case. So I benefited from mentorship by Professor El Khoury. I've seen and participated in a lot of ROS procedures now, and I know how to do that operation blind. But and for the future, I want to start my own ROS procedure program. But like Tyrone David said, in one of his papers last year, is that every surgeon who wants to start a ROS procedure program should have a mentor for the first 10. And then if they go well, then I would do it on my own. But I wouldn't start ROS procedure completely on my own, even knowing every little detail of every technique that like Professor Khoury said, in Brussels we have 3 different techniques for ROS procedures. And I know exactly every step and everything, but for myself I wouldn't start it without a proctor. So that's my personal experience. And I know that ROS procedures are picking up everywhere. Everybody is starting ROS procedure program, and I think that residents now will be exposed to it more and more, and and hopefully it's enough to when you come out as an attending to do it on your own. But for me that was not the case. I got my experience in Brussels.
Ismail, learning ROS.
I think learning ROS, I don't like this focus on one single procedure. I think it's really, ROS is no different than a bentol with a lot of technical principles and steps. So I think one has to decide whether you want to be a reconstructive root surgeon or reconstructive valve surgeon. Then you understand the principles of root, of valve repair, of valve sparing, and the ROS is just another step or another tool in your armamentarium. There's a lot of emphasis on how complicated and complex the ROS is. I truly don't agree with the notion that it's a complicated operation, but it definitely is an operation with many, many steps, and with there has to be a lot of attention to details in every one of these steps. Tying your shoes is only one step, very few details. And if you don't pay attention here or there, you can have what Yama was describing, a bit of AI or a bit of bleeding, and that can spiral out of control. So I think for residents or trainees who are interested, it's not about learning one procedure, but it's about understanding. First of all, it starts with anatomy. And I think what we're seeing now is less and less focus on understanding the dynamic anatomy of the aortic root, and then understanding the principles of the dynamic physiology of the root from the standpoint of symmetry of the commissures, height of the commissures, height of the leaflets, all of these things that tie into whether it's aortic valve repair or valve sparing or ROS, all of this together. Executing the operation then becomes a very simple thing. Obviously, you have to practice a lot, and you have to do, whether it's in wet labs or whether it's in seeing people doing it and then doing it yourself. But I'll give you my own experience, because I think it's, for all trainees, it can be of some relevance. In my training, I didn't see any Ross procedures. And then I did 4 years in the lab. My PhD was cellular and molecular. I was sitting pipetting and doing things for 4 years with Professor Yacoub. But I saw him on missions do some cases because he wasn't doing cases by then in the NHS system because of their mandatory retirement age. But through all these conversations and watching him do operations, I really got a true appreciation for how to see the aortic root as a 3D structure and everything that makes an operation a success or not when you're doing root reconstruction. And then we started our program in Montreal just that way. So I had seen him do about 10 Rosses in total, but then I went to a lot of courses, and Professor Akuli was very generous in teaching me, and Schaefers and others, where I learned you pick up small things here and there, and then you apply. But it's really, like I tell residents, surgery is a cognitive process. The handiwork is the execution of what happens in your head. And so there's no magic behind it. All these operations now have been broken down. Luckily, we're in an era where myocardial protection is so safe and so reproducible that you can afford to have longer cross-clamp times with very high safety. So you don't have to rush through these operations. And I think they're reproducible, but I certainly wouldn't suggest that everybody do Rosses and you're only doing 3 or 5 a year. That is a bad recipe. That's what happened in the 90s, and that's how the operation died for some time. But I'll be curious to hear what Jibreen has to say. He has trained legions of surgeons by now, and he sees it maybe differently.
No, I agree totally with what you said, Ismail. And I agree. I cannot agree more that the Ross operation is a part of reconstructive surgery of the aortic root, and you have to take it this way. You know, when we are discussing about sparing surgery, Marfan patient, normal valve, and you do sparing, and you have aortic regurgitation. And cardiac surgeon will tell you, some cardiac surgeon will tell you, I'm a sparing surgeon, but I don't touch the deflet. You cannot. It is not. It is impossible. If you are a sparing surgeon, you should know how to treat induced prolapse or uncovered prolapse or whatever. So exactly on the mitral side, you cannot say I'm only putting ring. I don't like to do the mitral valve repair or the cord or whatever. So it's the whole. You should really take the anatomy as said by Ismail. And you should also, you should understand the 3D configuration of the aortic valve. You should know how to use a stentless surgery, the homograft, it's a whole. You have to understand the anatomy, the functional anatomy of the aortic valve, and you have also to, for sure, to know some surgical techniques to address any issue we might have during the surgery. So watching, and have dare to start this program. You cannot always say, "Oh, it's difficult operation." Ross is very easy operation. You have to say it is very pleasing operation.
Yeah.
So, and I agree with Ismail when he said that. A lot of people say, "Oh, it is tricky surgery," but no. If you know, the only thing that's tricky sometimes is how to harvest the autograft. Yeah, we should learn how to do it. But the other things are really very easy. It is mental. You have to pay attention to some tricks, and that's all.
I love this concept. A lot of people send me a text and they tell me, or they get in touch with me and they ask me, how can I become a robotic surgeon? And I tell you that it doesn't exist a robotic cardiac surgeon. I am a coronary surgeon who knows how to perform a sternotomy multi-arterial bypass on pump of pump, and then a robotic multi-vessel bypass totally enclosed in the right patient. You have a tool in the hands of an expert that treated the disease. So Ross is a tool in the hands of the aortic expert who has the entire tool of skills with the aortic root. It's like saying Castro de Vello. I'm not a Castro de Vello surgery only. I don't close the sternum with a Castro de Vello. I love Castro de Vello as a tool into your armamentarium.
I have 25 years experience of Ross, and we have some redo. And I can tell you that patient I did on him Ross 20 years ago. Some of them came for redo operation, but I do sparing surgery, and they are also okay for 20. I mean, it's fantastic surgery for young patients, and it is the autograft is nearly forever. The patient 20, 30 years after they are there. So we have to encourage people to go and to learn to ditch the risk operation. It's a fantastic one for the patient.
But again, I would again caution against the notion of just being a once a month Ross and then once a month complex mitral. That's not the way that things should be done. I think these operations,
Ismail, if you do 10 sparing, if you do 3-4 repair,
absolutely. That's exactly it. As long as you spend time in the root space, and all these things become, then it's fine. But
if you do 30 sparing and 5 Ross, that's okay. Why not?
Absolutely, I'm correct.
The whole experience.
Yeah, absolutely.
So I want to start to wind up, and I want to say that we have three most very important messages that today I learned a lot. First message is very nice paper. Thank you so much, Jama. Thank you, Professor.
Thank you.
The concept that you should bring home for your Monday morning dental procedure, even if you're not an extremely highly dedicated root surgeon, but you have to do your next root next week, is think about the geometry of the annulus, the 3D positioning of the annulus, and think, even when you do a biodental with a prosthetic valve in a tube graft, that you are sewing a circular single plane into something that is 3D shaping and generally is lower at the non-coronary sinus. Be cognitive of that and imagine techniques like the one described by Jana to try to place it back again in the singular plane. Second element is be excited about aortic root surgery, particularly if you're a young surgeon. This is a terrific, incredible niche to take. Don't break it as a Ross surgeon, but instead embrace it as an aortic root surgeon that knows different techniques, different aspects, when to do aortic valve repair, when to do Ross procedure, when to do valve sparing, and when to do an aortic valve with a biodental, or when to implant a mechanical valve. So know your elements, know your things.
One more thing also, which is really very, very helpful for us, is how we do the redo route. It's really fantastic, this surgery, how we can, let's say, discover or know better deeply the anatomy.
Yeah.
The redo route really teach you the anatomy of the root. So that's fantastic one. So don't be scared to do redo root. It's fantastic surgery and really help you to understand the real anatomy of the root.
Fantastic. So we want to say thanks to everybody. Thank you, Professor El-Khoury. Thank you, Ismail. Jama, thank you so much. Thank you for coming. Thank you for everyone who watched the session today or will watch it on stream. And keep watching this live. We are just here with a coffee in our hands on a Saturday morning to learn something from experts. Thank you so much. And
Gianluca, thank you for bringing us together, and congratulations on all the work you've done with this session. It's always a pleasure to watch you on these Saturday mornings.
It's excellent idea, this discussion.
Yeah.
I like.
We'll still. I think I'll keep Jibrin online for another hour just to keep asking him questions.
I want it too, because we have to reorganize another one, because I have so many questions to ask you both, and particularly on the distal anastomosis of a Ross. Because so many people don't pay attention on the distal anastomosis of the Ross. It's like the proximal anastomosis of a coronaries. Is where you get the stroke, but nobody care about that. We are always talking about how you do your distals. How you do your proximal is more important in coronaries than nothing else. And there is a lot of similarities in root surgery. But it's an hour and 9 minutes. And I think it's time to wind it up. We will reorganize something like this. It's a beautiful talk, and thank you a lot, everyone. And please go to Journal of Cardiac Surgery, read, and submit your paper there. Thank you so much.
Okay.
Thank you, everyone.